Well, today at the A E-AHPBA podcast series, we've got Manuel Maglione, sorry, I'm pronouncing it wrong again, joining us from uh, from Innsbruck. He's a consultant HPB surgeon, and the reason we're having him as a guest today is he's one of the leading members of the upcoming guideline meetings in Innsbruck next week, where we're gonna set some guidelines for the perioperative and postoperative management after liver surgery. So, well, happy to have you today. Thanks for joining and doing this. So, we'd like to just to start off by having you tell us a little bit about yourself, a little bit about your career and how you got where you are.
Okay. Well, thank you, Steen. Thank you for inviting me. I'm honored to be a part of the series that you started. I think you told me that with the first interviewee.
You are
So
indeed,
happy to
yes.
be here. And well, as you said, I'm working at the University Hospital in Innsbruck as a consultant in HUB and transplant surgery. I'm leading the HUB group. I started my career, my medical career here in Innsbruck, meaning I started studying here. Then there was at that time when I started studying and working in Innsbruck, there was a Professor Margreiter who was a pioneer in transplantation surgery. So I did my MD thesis in transplant surgery, and then but did my residency here in Innsbruck, spent a year in Oxford, and there I sort of started to see also HPB surgery and sort of fell in love with the surgery as well. And so these are just my two main topics, HPB and transplant.
So you were in Oxford for a fellowship then, as a fellow, or
I
was it?
was there for a clinical senior fellowship
Yeah.
in Pete Brand's group
Oh, yeah.
with Michael Silva, Sunawala. So it was already 10 years ago, a little bit more. So, but it was a very good time. It was a
Yeah, it's
very
a
good
nice
time.
unit, isn't it, in Oxford, I believe.
Sorry, say it again.
It's a nice unit, Oxford, isn't it, the HB?
Yes, yes, definitely,
Yeah,
definitely.
and it's a
So it was a
gorgeous little city as well.
so it is, so it is. So it was from a personal point of view and also from working point of view. It was a perfect location for me. Yeah.
Yeah, great. Well, I've been in the UK myself as well, so I know a little bit how it is. But it's nice that you're now back in where you started, basically, in Innsbruck.
So it
And
is. Yeah, yeah, yeah.
so, what else? What if you're not when you're not practicing surgery? Do you have any other things you like to do with your days?
Well, the rest of the days are pretty full with family, meaning with two children, 8 and 11 years old. So there's plenty of things to do and plenty of time to share with them. So for me, it's a plenty. For them, it's always not enough,
So it's
but
two
it's but it's okay.
two full-time jobs, basically.
Full-time job, exactly, exactly.
Well, you
Yeah.
And you told me so you're HB and transplant surgeon. So what's your practice like? Do you do like the full breadth of surgery or?
Yes, meaning so it's we sort of in the last years it's we sort of split up in different working groups. So regarding elective surgery, I'm doing mostly HPB,
Yeah.
and then I'm on call on road approximately 7 days a month, being on calls for transplant.
And you do HB, you do both pancreas and liver then basically.
Yes, pancreas and liver, and transplant we're doing liver, pancreas, and kidneys. So
Okay,
the abdominal.
that's a good practice then. So now we're basically we wanted to talk to you about the guideline meetings, obviously, and you've got a bit of experience with that as well because the last time you've organized some guideline meetings in Innsbruck as well. So I think it's the second time you're organizing guidelines meetings
It's the
lately.
second time. So it's so that we started to already 6 or 7 years ago. We started already to do this Surgery Innsbruck series, which was part of a educational meeting or educational yearly meeting that we've done that we did. And then 2 years ago, since we had very good talks, very good faculty members, we came up with an idea why not trying to evolve this meeting and try to do something which then is not just a meeting, but then which you have something in your hand like a paper. And then we said, well, why not try to set up a consensus meeting? And we tried it 2 years ago. It went very well. We had a good publication in BGS, and we said, okay, we could do it every 2 years because every year it would be a little bit too much.
Yeah, fair enough. Yeah.
working lot of point of view, and so in a 2 year, every 2 years we plan to do such a consensus meeting in the next years in Innsbruck, and we switch it once a year. We do a national meeting, just a sort of educational meeting, and then every 2 year we do the international one. That would be the
This
plan.
is not combined with an educational meeting now this time around, is it?
It's yes, but just for the Austrian residents, meaning the first part of the meeting, the first 3 sessions are sort of educational, showing we have the first session which will cover the prehabilitation, or the part before the operation. The second part of the meeting, or the second session of the meeting, will just cover the treatments for primary tumors and secondary tumors, metastasis. And then the third one, we have this video session dealing with complications and tips and tricks. And then we start a consensus part. So we just want to have a little bit of educational part as well.
Yeah, that's a very good idea, isn't it? It's nice for everybody. And that's basically for the Austrian trainees then, the setup for this.
Yeah, exactly. It's open to everyone, but it's just for the Austrian trainees. So we have it's just one of the regarding monothematics liver surgery meetings. It's we have currently 2 in Austria, but this is the bigger one, and so we try to employ it in a sort of a educational pathway, which could be done every year in Austria. So we're not yet there, but we're working on it.
Yeah, so before we go into into depth of the guidelines, obviously, so these guidelines are set up by the famous Delphi method, obviously. But people hear a lot about that. But can you sort of elaborate a little bit more on why the Delphi method is so commonly used in the setup of these guidelines, and why that is important way of doing it?
I think this Delphi method is a very good method to have all the opinions come together of all experts. But the Delphi method sounds like the method per excellence if you want to achieve a high evidence data, but that's not true. So we have to understand that the Delphi method is just it will never replace any randomized controlled trials. It will never replace any meta-analysis of RCTs, because it gives an idea of all the data which are outside. So it gathers the data which are available, and then combined with the experience of the experts that we try to gather and to convince to work with us. So, but it's a very good method to see different perspectives and to discuss topics which we may think that they're can manage in one way, not in another. But then when you speak with other centers, with experts with other centers, you see that sometimes there are more weights that lead to Rome, let's say it this way, and they may be also effective, if not more effective. So we have different schools, and it's a good method to compare the schools.
Does it? I sometimes get a feeling though with the Delphi method, it opens the door slightly to a little bit of sort of bias or expert bias. What was your feeling about that?
Good point, because if you're lucky enough to invite the experts to the Delphi meeting, many of the experts have written the papers as well.
Yeah.
So there might be some criticisms are that there could be developed some group thinking in this Delphi method, and sometimes also tiredness. If you have 30 questions to answer in comments, so it's on question number 25, you should maybe just save all the comments you've done and then restart the day again the day later, because the last 5 will be tough.
But that's quite a good point what you're making, because I've been at some other guideline meetings in the past, and I must say that some of these guideline meetings have this boatload of questions. And what I quite liked about it, because I'm a member of the guidelines meeting myself now this time around, and what I quite liked about it is that it's actually quite the amount of questions were quite limited, which I think is good, because then you will at least prevent people getting tired of questions and just racing through them without really thinking about them.
So it is, yeah. We tried also to have this 5 or 6 subtopics, 5 or 6 general topics, and then subdivide them in a few subtopics, but not having too much. So it's, I think the 32 to 40 questions for a guideline is okay for a consensus.
Yeah, because what were the topics of this meeting? What are the 6 topics?
So the topics are just it's sort of a peri and postoperative management following liver surgery. So we're talking about antibiotics, so we're talking about anticoagulation before the treatment. We're talking about prehabilitation. We're talking about a small part of the prehabilitation, meaning the nutrition, for example, and the how do you call it, nutrition, and now I have to cut this, and um, um, physical preparation, yeah, of the patient. Then when we're dealing with bile leaks, bleeding, and then also the postoperative liver failure, but more looking at the later events, meaning after 30 days and 90 days, the late posthepatic liver failure. So these are the six topics which are covered. So three are regarding the part before the surgery, and the other three the part after the surgery. And we were just we were curious when we started this project 2 years ago or 1.5 years ago, also to focus on these complications, because we're dealing with complications, so we cannot promise a surgery without any complication, and since we have to understand that most of the complications are dealt with together with other disciplines in an interdisciplinary way. So it's even more important to understand maybe which structure in a hospital do you have to be ready and to be allowed and to safely perform such surgeries like liver resections.
Yeah, exactly. So to prevent failure, to rescue, and all these kind of things, and get a
Yeah,
bit of better
exactly,
understanding.
exactly.
Yeah, because that's always a question. I can imagine when you're sitting there with your group of people and think we're going to set up a guideline meetings regarding, well, in this case, liver surgery. Why did you, well, you sort of elaborate on that a little bit again, but why did you sort of pick this subject specifically? What do you feel are sort of the hiatus in the current practice of that made this specific not guideline necessary?
Yeah, yeah. So it's all part of a bigger project, which is sort of trilogy. Meaning we started 2 years ago with this very specific topic of posthepatectomy liver failure, just covering just the main, let's say the main problem in complex liver surgery that patients may encounter. And then we said, okay, we have covered this one, and then let's see how to optimize to try not to repeat the ERAS guidelines, but to have a perioperative setting, looking more at the complications, and then uh, the not it's not midterm follow-up, but just the follow-up of the for 30 days, and how to prepare the patient, how to treat him best, and how to avoid any failure to rescue during the first 30 days. It will be this meeting, and the next meeting hopefully will be in 2 years. We would like to cover the follow-up, the oncological follow-up
Oh yeah, that's a good
in
point. Yeah, so
in
sort of
liver
the middle to
transplant.
long term kind of.
Yes, exactly.
Yeah.
This would be so part of the trilogy that we thought to plan.
And then the next step will be pancreas, probably.
And then the step would be pancreas. It will depend a little bit on the steering committee. We'll discuss it, and it depends a little bit also on whether there will be still a place for consensus meetings. So it's currently it's rather modern. It's we're just on the wave of this consensus meetings here. We're riding the wave. We're riding the wave. We'll see in 2 or in 4 years how it will develop. Whether
Yeah.
this consensus meetings, the stealth meetings will still be modern or not.
Well, that's an interesting point you're raising there, because obviously there's a lot of consensus meetings
Yeah.
going on at the moment. I think in the last few weeks there have been several consensus meetings already. I think one in um, perfusion for explant hepatectomies, and there's
Yes,
one
I've heard. Yeah.
perihilar cholangiocarcinoma starting
Exactly.
this
Yeah.
weekend, I
Yeah.
think, and now yours.
Yeah. Yeah.
So, what what do you think one could do to really make your own consensus meetings stick out in the field of all the consensus meetings? How have you sort of prepared or planned to really make sure that people actually
Yeah.
find your meeting?
So from so the first point was, so the first idea was to design the questions and the topics as close as possible to your clinical day life, so
Yeah.
that this consensus will sort of um, give you maybe some hints, some answers, some ideas for your clinical practice. And so and we tried also to cover topics which are interesting not only for highly experienced centers which are doing, let's say, 200 livers per year, but also those which are still reality, which are doing, let's say, 10 or maybe 20 livers, sometimes also combined with complex liver resections per year. So to have this to have with this guideline a very broad and very wide perception, very wide audience, and which then might then reflect also or reflect maybe in a good quality of the clinical daily life of the patient of the surgeons which will read this guidelines.
Yeah, but equally the patient as
So,
well. I think the patient will benefit.
and then in the end for the patient as
Yeah,
well. Yes,
yeah, yeah.
exactly.
And so this is obviously, I think it's endorsed by obviously the E-AHPBA, but also ESSO, I believe.
But yes, so it is. Yeah, also by
And
the ESO and by the Austrian community as well, by the Austrian Surgical
yeah, but
Association.
obviously also a good way to get it amongst the people that
Yes,
needs to be.
yes.
Yeah, yeah.
And this
Uh,
maybe, yeah.
Sorry?
No, that doesn't, as you said, it helps obviously to if you have the endorsement of this big association, it helps obviously also to spread to spread this message and that the people maybe can join. Yeah.
And when you look at these guidelines, I think this is a very good guideline because this is so, yeah, basically elementary, so basic actually
Yeah.
seeing liver
Yeah.
surgery. And I think a lot of centers are really in need for a change of some of their protocols, and this will really help going forward. Just to look at little things, what to do with anticoagulation and antibiotics and all
Yeah.
these kind of
Yeah.
things. These
Yeah.
are just
Yeah.
the questions that a lot of clinicians and surgeons have in their daily practice. And I know that a lot of people always, you get these questions or you ask these questions to your trainees yourself as why would we do this or why would we do that? And sometimes you don't really, it's really
Yeah,
difficult.
you said here. I've always done it like this. So
Yeah,
that's
exactly. That's the
that's
thing
the
we want
answer.
to
Yeah.
overcome, obviously. Yeah.
Yeah.
So in these guidelines in general, so I mean, how? Because I can imagine, we've got these guidelines now. You had the post-hepatectomy liver failure guideline a few years ago. What do you think is the longevity of one of these guidelines? How robust is a guideline, and how often, in your feeling, does one need to revisit a guideline, the shelf life basically of a guideline?
Yeah. Yeah.
Yeah,
We think that the shelf life would be about 5 years.
yeah,
So maybe after 5 years, you might just try to recapitulate and to reevaluate the literature which is available. So because you were talking whether in two guidelines to the pancreas era will start for our meeting, we could also, since then 5 years have already passed, we could also restart again with the first guideline.
yeah.
So
No, I think
I
that's.
think 5 years are okay, and things are changing very fast. So it's you as a steering committee, you can then have a look in the literature whether practices have changed or not, and then you can decide whether this 5 years should stick 5 years or maybe they can stick a little bit longer as well.
Yeah, and do you think there are ways I'm just sort of spitballing here, where uh, how we can reach out to the sort of general surgical community or the HB surgical community to see what questions are out there, to sort of decide what the next guideline meeting should be like. Can you imagine
That's
doing a survey or something?
That's a good point. That's a very good point. So so far we have the plan for the next 2 years, but then if we think about the meeting afterwards, meaning in 4 years, it would be definitely a good point to make a survey which questions are burning currently in the HB surgery, and then we would definitely need the help of the E-AHPBA, for example, to set up a survey and to reach out to all the to all the members and to all the surgeons to see which topics could be discussed in an upcoming meeting.
So going back to the meeting, I mean, and your own role in the meeting is, I must be a bit challenging. I can imagine. Like I can still, I still get some late night emails from you, so you must be working really hard with it. So what do you find as a personal the biggest challenge in setting up these meetings and leading on as a steering committee member?
Um, well, to be honest, the biggest challenge is to find some sponsors
Oh yeah,
because it's we are the main goal is to go break even, and we're almost there. But it's not that easy because after following the last year, so the well, everything became much more expensive, and but the sponsoring is still the same. So that's probably the most difficult part, and probably also the most difficult because it's not the thing that you're doing every day. So you have to go there to a sponsor, say, "Hello, here I am. We're writing this meeting. It would be great if you could sponsor us." And well, and it's not nice to go for begging for money. And let's put
No.
it this way, very simply said. And then, to be honest, and then getting it's always interesting how enthusiastic the people you ask for, if they want to collaborate, they are. So it's we really we let me just think. I think we had one or two people who said, "No, really, it's good, but I don't have time." But all the others said, "Well, I'm in, so I'm happy to collaborate."
Yeah.
So that's the easier part. And then, as you know from your own experience, some are enthusiastic at the beginning, but then enthusiasm flows down
Dwindles
a
a
little bit.
bit. Yeah.
Well, yeah, and then you have to re-encourage them to work
Yeah.
to work together, but to work and to stay with us. But yeah, that's part of the game.
A lot of
That's
chasing of
part.
people. Yeah, that makes
Lot
me
of
wonder sometimes. It's a difficult balance to strike. I was talking to one of my committee members yesterday or the day before about obviously it's good to have a lot of people to divide the work, but also there is a point, where is the break-even point? Because you can also have too many people
Yeah.
where some people do very little and a lot of other people take on a lot of the load. So do you think there's like an ideal kind of balance in amount of people one can strike, or do you?
That's a good question. I think what we thought is to have just one. So we have this 5 to 6 group of faculty of experts or faculty experts per topic,
Yeah,
and then these five people can be split to the subtopics. Um, so in my opinion, 5 to 6 is enough.
yeah.
So as you said, not everybody will work as much as the others. There will be some who do less, others more. Um, it's difficult because most of the thing is also you're not doing it on person. So meaning it on site, you're doing mostly this meetings with the video calls, and so it's sometimes it's a little bit impersonal. So it's probably harder to reach the people also from an empathic and emotional way. So that
Yeah.
doesn't make it easier. It would be probably easier if you would organize, let's say, because there's a process of which is going on of 1.5 years. If you would have the possibility to organize, let's say, one or two meetings in between, so just one day meeting at the airport, airport hotel, for example, where
Yeah.
everybody can reach easily. And then you might also you can engage a little bit better with all the faculty members, and then you might also feel a little bit more um, obliged to work in the topic. But
I
that's then
By saying this, you answer another question I had. Do you feel like these meetings should be held in person, or do you think a completely virtual guidelines meeting could also work? But I think you've sort of answered that question
yeah,
by
yeah,
saying, an in-person meeting will be much more efficient and effective. And maybe one way to come around this, I mean, obviously we got our yearly meetings like the IHPPA, and then followed by the E-AHPBA meeting or the SO
yeah,
meetings. So you could
yeah.
argue that if you have a year and a half or 2 years in advance, that you could set up a steering committee meeting at one of the main meetings. I'm saying, think that's always possible. That's something maybe you could consider going forward.
That's a good point. Yeah, we didn't think about it, but that's a good point because then most of the people which are joining the consensus normally go to these meetings.
Yeah,
Then could just
could
meet
do
meet
a
her.
hybrid thing at the next
Yeah, yeah, yeah,
meeting, and then get some
yeah,
people there, and or even just the group leaders for that matter. Yeah.
yeah, yeah.
Um, so, I mean, you get a lot of experts, and I think that's quite good to have the experts in the field because that's, guidelines are obviously made by people who have a lot of experience. But I think it's also interesting for younger surgeons who are interested in playing a role in kind of guidelines and bringing the field forward. What would your sort of, first of all, what's your view on having some maybe junior members in the committee? And secondly, if you think that's a good idea, how would a young surgeon, find his way towards a guideline committee meeting? How would you advise somebody to take part in that?
The question is how would you define a young surgeon, meaning somebody who's doing his residency still, or somebody who's already a
Yeah,
uh,
probably an early career surgeon. So somebody who's just finished their basic training and is maybe doing a
yeah,
fellowship, or is a young
okay,
consultant in sort of the
yeah,
first few years of
yeah,
of their consultant practice. That's basic. I think I think much younger might be a little bit difficult for
exactly.
like, but I think a young surgeon who's in their first maybe 4 or 5 years of their consultant
Yeah.
career, or yeah, or fellowship or something like that.
So we try to have a little bit to have a balance between older and younger surgeons.
Yeah,
So the point was when we sort of set up the faculty to have as much Europe as possible covered by the experts. Um, we also looked for the gender equity, even though it's rather difficult in surgery. Still, it will become definitely better in the next 5 to 10 years probably. And we looked also for having some younger surgeons as well. But you need a certain amount of experience, I think,
sure. Yes.
in your in your career, in your HPB career. And then the other thing is, the younger you are, or there might be a difficulty if you're in such an expert group, meaning that there could be even the problem that the youngest will do than everything.
Yeah.
So this can be this disbalance as well.
Yeah, and do you maybe are you also maybe fearing a little bit that younger group members might be overshadowed a bit by the older experts and might not
Yes,
willing to speak their
this
mind? Yeah,
this as well. So it's hard, and so we try to balance the groups also in this way, that to have it a little bit not too homogeneous groups, and so that's but it's not that easy to find the right balance. But definitely we need the younger surgeons as well. So as you said, they need a few years of experience, let's say 3 to 4 years in experience in HB experience, to to have lived up with these topics. And also if we talk about complications, so that's good that you have people which experience the complications as well.
and obviously you will look at a diverse group of people as well. And
Yeah.
2024, it's very important. I think that we try to be diverse as well, and then that's basically. I mean, if I look at the people you've invited already, the guidelines, it's a quite a diverse bunch of people, which is really good to see. And
So it is, yeah, yeah.
yeah. Um, Yeah, what makes a good committee member? What's an ideal committee member for you? What's your
What's an ideal committee member? That's um to be it's ideal committee member to answer in a quite regular way the emails that have been sent, and to be available, sometimes also flexible regarding, because we have the steering committee um, gatherings or phone calls, mostly in the evening. So it's not it's because it's impossible during the working time. And I think you have to be as a committee member, you have to be convinced about the idea. If you have some skepticism, so you will not live for the idea, for the consensus meeting.
yeah
And yeah, so you have to be passionate about the idea, and passionate about the field you're working in, and working in, about contacting and connecting with other people.
yeah fair enough. So I think I'm feeling we should start to wrap it up as well. But um, maybe it's another question. I think if people listen to this sort of podcast, is there a way for them to join virtually as well, or can they only come in person?
There is a way to join virtually. Yes,
Yeah.
they can join virtually.
And
So
there will be a link
um,
somewhere where they can find that, or maybe you could share that one with me later after the meeting, and I can share it
I
on our
can I
on
can I
the
can share the flyer with the link with the
yeah
program. So
yeah
there's
be
a link
good
they can.
yeah
Yeah.
All right,
we
that's
can do
good.
this. Yeah.
And few other questions. So it's in Innsbruck in December. Is that it's a good time to be in Innsbruck? Obviously. How is
It is definitely a good time, yeah.
what are the snow forecasts? I think some people would want to know that as well.
So there won't be so much snow as far. Let me just check. Let do it.
Yeah.
Seeing this, I can I can check it now. So the forecast for next week, if and today is December the 4th, so in 9 days, will be so it will snow on Sunday.
Hmm.
So there might be some chance that we will see some snow still in the, but it will be sunny on the between. It will be sunny, but a little bit frosty. So around the 0 degrees, -5 to 0 degrees. So there will be some snow maybe left, not in the city, but at least in the mountains.
So it's another good reason to
So
join.
yeah, that's another good reason to join.
Excellent. Perfect. So it's going to be 12th and 13th of December.
Yes,
Yeah.
exactly. 12th and 13th of
And
December. So
in
the
Innsbruck, obviously.
consensus.
Yeah. And
So sorry.
no, no, go for it. Go for it. Yeah.
Just so we will start on the 12th, and we have the first day mainly of the educational part, and then in the evening, however, on the 12th, we start already the consensus
Yeah.
meeting. So and
Okay.
the nice thing which will be also the video session that we have in the
Yeah.
after the lunch break, so that we will see how so tips and tricks how to avoid complications, but how complications intraoperative can happen, and then also how our radiologists, our endoscopists can manage some complications in a rather minimal invasive way compared to reoperations.
That will be of great value for a lot of the attendees, I think.
Definitely.
Well, I myself look forward to it a lot. To see you next
Good to
week,
see you
and
as
I
well.
hope we get a lot of people to join, and maybe after seeing this, also joining online. Do you have
Perfect.
any other things you wanted to share before we dial off, and then any other remarks you want to make, or a quick sales pitch you want to do?
I think I'm fine. So I'm really honored that you invited me for this for this chat. And it's I think it's a good platform to share ideas. You gave me already some good ideas for the next one regarding the on-site meetings, the meetings that we could do during the process, and uh, so it was great. So I really hope to see you as much as possible in a hybrid way or on site in Innsbruck, and looking forward to see you and to meet you in Innsbruck as well.
Yeah,
And I wish you all the best for this for this podcast which started today.
yeah. Thank you so much, and it was a pleasure speaking to you, and we'll meet soon in person.